Thank you very much for the introduction. I'm Nick. I'm a dermatologist for Norfolk and Norwich Hospital. I have a variety of other jobs which are listed here, but I'm here speaking, tell you about my personal views, which aren't necessarily the views of any of the organisations which I work for. So artificial intelligence is such a hot topic, isn't it now? It's such a challenging topic as well. We all read about it. We try and understand it. I don't think anyone really understands it, do they? It's an incredibly difficult and challenging area. It's also changing all the time, isn't it? Just when I was preparing this talk in the last few weeks, I thought you always look around for images for your talks to try and make them sort of more interesting to sort of catch people's eyes. And I came across this new thing called, what was it called? Copilot, which is the AI, which is attached to the program I was using to make this presentation. I thought I'd just type into it, show me a picture of a bald old man wearing glasses giving a presentation. And it came up with this. That's actually pretty good, isn't it? So I thought that is good. And yeah, it's sort of interesting what it can come up with. So the images through this are mostly generated by AI. And some of them are okay. Like this, which is obviously highly accurate, but other ones are less so, as we'll come through. So what do we mean by what are we talking about? AI in melanoma diagnosis and melanoma pathway. So AI is computers which can think in a way which would normally require human intelligence. And when you're designing an AI to diagnose melanoma, the way you teach the machine is it learns by looking at thousands or even hundreds of thousands, or I know for breast cancer, the images being used are up to millions of images being looked at there. And the computer learns from that what is harmless and what isn't harmless, because each image is labelled as being harmful or harmless. And in that way, it learns how to diagnose. It may do so in a very different way from which humans do. And the thing about AI is you don't necessarily know how it's working it out. And you can sometimes find very odd things. For example, if the machine was able to read the harmless or not harmless thing, it might just do it that way. And people have found when looking at AI, there's all sorts of mistakes you can make when training machines, but that's basically how it does it. And hopefully, it keeps on learning. It's learning all the time. But some AI is continuously learning and evolving, but the types of AI used in melanoma diagnosis, you tend to teach the machine, you produce version 1, you then get a load more images, you teach it again, you get version 2, you teach it again, you get version 3, and hopefully each version is better than the last version. But that's not necessarily the case. And that is one of the challenges in AI, is the new version definitely better than the last version? It should be, but it might not be. So what do they tend to look like? And they tend to look like an app, which is just run on your mobile device, on your phone. It's just a bit of computer software written into that. So you need to have often it has a special lens. You're probably all familiar with dermatoscopes, which are the fancy magnifying glasses dermatologists use with polarized light to show whether it looks through the surface to see whether what a mole looks like underneath the surface. And they often use that. So it's basically a mobile phone with a special lens attached usually. And one of the questions is how accurate is it? How good is it? The question really is, can anything or anybody be 100% accurate in diagnosing skin cancer? Can be 100% accurate in anything we do? Who was it who said to err is to be human? And is there such a thing as a human who never makes a mistake? And if there is, what does that human look like? That human who behaves like a machine? How can that be the case? And do machines ever make mistakes either? So I was trying to sort of explore this because I thought, I'm a doctor, but I'm also a human as well. And my dad had a 5mm melanoma, so I'm high risk of getting melanoma. So I want to know as well, when I retire in a year or so's time, what is the risk if we encourage people to produce AI? But I'll be going to my GP in 3 or 4 years' time when I'm retired with a mole, and if I show my AI and it'll say, yeah, it's okay, and I'll go away and it won't be. You know, what is that? What is that risk? So we all have a sort of self-interest in this. And the challenge is that all humans can have off days. I know this. I've been a doctor for a long time now, 40 years, and I know we all have off days. Doctors we're humans. We have bad days. We have days when we've had arguments with our family, or we've had a bereavement, or you're ill. And on those days, your performance isn't necessarily as good as it should have been. If your last patients, if you've had an unfortunate consultation with last patient, it's sometimes very difficult to put that behind you for your next 2 or 3 consultations. It carries through. So I know as humans that that my performance as a doctor varies day by day, according to a bit to how on the ball I am. And some melanomas are obvious to a doctor, but some melanomas, especially the early ones, can be very difficult to distinguish clinically. And you can be looking at it thinking, well, is it, isn't it? How do you tell it apart from a harmless mole? And even when it's being cut out, some moles are obviously benign, some melanomas are obviously melanomas, but there is an in-between group where quite often we sit there in the pathology meeting with the pathologists discussing, is it or isn't it? It's right on that borderline. What should we say to the patient? Should we say it is or should we say it isn't? Knowing there's consequences whichever way you go. So we tend to err on the side of caution. Because of that, you get a bit of a drift, maybe. So humans are never 100% accurate, but we also find AI isn't 100% accurate either. So what do we do about this, as all of us as potential patients? Well, what it means is that you have to safety net. So if somebody tells you that your mole is harmless, you say, okay, thank you, right, I hear you. You go away, but you remain a bit of sort of, you're careful about it, you think about it. And not only because the person might be wrong, but also because that mole might change in the future anyway. That lesion might change in the future anyway. So it's really important, if someone tells you something is benign, listen to them, say thank you, go away, but at the same time watch it. And if it continues to change in size, shape or colour, becomes irregular, asymmetrical, something about it bothers you, then please do ask for further advice. And that's the most important message of this talk, whether it's AI or a clinician, do that. And there's some great handouts we've got in our bags, aren't there, from Melanoma Focus, giving you instructions how to monitor your lesions to look out for melanoma. So please follow that. So what is the melanoma diagnostic pathway which the AI might help with? And actually, the diagnostic pathway isn't constant throughout the NHS. It varies from department to department, from unit to unit, which depends a bit on the geography of where you are. If you're working in central London, the way you set up a health system is very different from if you were living in the Hebrides or living in Norfolk, rural Norfolk, where I am. And the structure looks slightly different. But there are some key stages which everybody goes through, or most people go through, in their path to being diagnosed, which I've tried to list here in this. Sorry, this is my worst slide with far too much writing on it, but I've tried to simplify the pathway as much as I could do. And in red, I've put the areas where I thought an AI might be actually applicable, either now or in the future, in the pathway. So at the top, there's self-monitoring, and obviously when you're monitoring yourself, you could be using an AI and a mobile device for that. And at the point at which you decide to go to the doctor, where you make an appointment, maybe the AI could be helpful in helping speed up that process of making an appointment first to see somebody in primary care. Or the way it analyses, if you send a photo to your GP, maybe the AI should be involved at that stage, looking at those photos, helping to guide either you or the GP as to whether the lesion is a problem. And maybe the GP, when you see the GP in the practice, maybe they should be using an AI there. Or you see a nurse in the practice, maybe they should be using an AI to help them make a diagnosis at that point. And then when you get referred up to the hospital, at that point, when that referral gets sent up as a letter or as an image up to the hospital, that's the point at which we should be doing the AI. And that is the point at the moment where a lot of the AI research is looking at that point. And And then maybe a specialist should be using it in the hospital to help them make decisions, to help them out when they're having that off day. Maybe it should be, if they decide to cut out your lesion, maybe it should be managing the waiting list, helping to get the waiting list optimal. After it's been cut out, we all know sometimes there's unacceptably long waits for your report back from the lab when you've had a lesion cut out. And maybe the pathologists could be using AI to help them either select which lesions to look at first, or to help them make a diagnosis. Those are all areas, I think, in the diagnostic pathway where at the moment AI has been tested and been used in some of those areas, but it's all changing so rapidly, isn't it? But I reckon in 5 years' time, it'll probably be there, but also in many other areas. So I've looked at some of the sort of areas in the diagnostic pathway where an AI might be used, and just had a few thoughts about this. How about, the screening apps which we pick up on the mobile phones? And, I've already heard, we hear stories about these being successful or missing melanomas or causing problems. And I had an experience when I was working, about 10 years ago, when a computer scientist from one of the places I work approached me and said, I've got a new way of programming an app here, and I can diagnose melanomas. I thought, that sounds interesting. So I got involved with it. I helped him a bit. And then very quickly he was saying, let's now launch it out as an app. And I said, well, hang on, don't we need to do a bit of research, a bit of testing first to see if it actually works, how good it is? Mrs. Melanomas said, no, let's just get it out there. So we put it out in the App Store. We can charge £1 an app. There's hardly anything out there 10 years ago. And if, say, 100 million people download it, that's 100 million pounds. That's 50 million to me and 50 million to you. At that point, I walked away and didn't get involved. And but that's the sort of danger. There's a lot of money involved in this, and sometimes people can sort of get drawn into that. And there's lots of apps out there. I'm sure you've all come across apps which will claim to be able to diagnose. And the problem is a lot of them just haven't been tested properly because the testing is incredibly expensive and takes a lot of time. So it's much easier just to launch it out there. You can pick up an app from anywhere in the world. So I'd say, yes, it's out there, but just be cautious about it. Also, there is a bit of a problem, is that there's 50 million people in England, each of whom maybe has about 20 lesions on their skin. So those of you who are sort of mathematicians will be thinking 50 million times 20, that's 1 billion lesions. So there's 1 billion lesions out there. Imagine all of those were being looked at by an app every year. And the app decides, maybe just to be on the safe side, 1 in 100, which are benign, it'll say it's cancer, just to make sure it's not missing any. That's 1 in 100 of 1 billion, which is 10 million lesions. So there'll be 10 million people by the app's being told their lesion might be a melanoma. And if all of those got referred into the NHS, the people with real melanomas would not be able to get in because of the crowds waiting at the door. And that's part of the problem with the screening issue, and screening something where there's huge numbers of people there. So there is a problem there with potentially causing waiting lists. How about primary care? This is where I actually think there's probably the greatest potential, because often it's really challenging if you're a new member of staff out in primary care. You might not have had very much opportunity for training at all. So if you're a new nurse that's been put out, or a PA, physician associate, being put out into primary care, you might have done very little dermatology. Even as a GP, you may have had a few weeks at medical school, but very little other training before you're actually put out there. And suddenly you're faced with people coming in saying, is it or isn't it? And of course, it's a life-changing decision, isn't it, if you get it wrong? You can't refer everybody up, because if you do, you overwhelm the service, and the people with proper disease can't get through. But then if you say no to people and you're wrong. So I think in primary care, there's a real opportunity. You've got an AI to be able to support diagnosis there. Personally, I think that's where it has the greatest potential. And then the way it is being used mostly at the moment is in triaging into secondary care. And what we've found recently is the reason waiting lists are long in secondary care, one of the reasons, is because the number of referrals of suspected melanoma, suspected squamous carcinoma, have gone up hugely over the last 10 years. It's been a huge increase in the number of referrals. And there hasn't been the same expansion in doctors, and to be honest, you couldn't expand doctors and hospitals enough to cope with this increase in referrals. So that increase in referrals isn't because it isn't all because skin cancers are going up. They are going up, but a lot of it is because a lot more people with benign disease are being referred up, which is a good thing in one way, because it means that hopefully we're missing less melanomas as a consequence. But on the other hand, it makes it much more difficult to provide a timely service to everybody who's been referred. So one idea is then you've then got a machine which can select out the sort of 10, 20, 30% of people where the lesion being referred up is very, very likely to be benign, and send a message back saying, no, that's okay, just keep an eye on it. And that's the way it's been looked at the moment. How about its use in histopathology diagnosis? And again, this is something which I think has great potential. My friends who are histopathologists think this will be very useful. Probably not in taking over from the histopathologists, but just in helping, if they've got something which they think, a slide which they think is benign, if AI just does a double check on it and just make sure, then it makes them less likely to make mistakes as well. So there may be a way for it to speed up the histopathology process. And then the other area I think it has great potential is actually in giving out information. All of us, when we get a bad news diagnosis, I know this, when somebody tells you some bad news, your mind goes blank, doesn't it? You stop thinking. And you can't, well, most of us do anyway, and it's very hard to continue to take stuff in. You're shocked. And it may well be that AI is able to help offer people information in a way about their diagnosis, in a way which is easier for people to understand, either at a later date, and maybe the AI will be good at using language which is most appropriate for you. If you're a professor of physics somewhere, it will use language appropriate for you there. If your literacy is very low, it will use the appropriate language. If you speak a different language, if your first language is not English, then maybe it'll be able to help you there. So I think there are ways in which the AI may be helpful in giving out information in the future as well. Obviously in conjunction with humans as well. We all want the human touch in that situation more than anything else. But having some people also, the combination, I think, a sort of hybrid approach of machine plus humans is perhaps what will happen. So the million-dollar question is, which is better at diagnosing melanoma, computers or humans? And that's a really difficult question to answer. Because there's not actually been that much research done, and doctors are missing that. We've not really done the research looking at how good we actually are at diagnosing. There have been odd studies from, if you look back, there's probably 20 or 30 papers out there in the whole world literature, out of the probably, I don't know how many papers have been on melanoma in the last 5 years, probably 100,000, but only a very small number looking at the accuracy doctors have in diagnosing melanoma. But this was identified when we started asking this question. We started looking at AI. People reasonably asked the question, well, how good are we? And we thought, actually, we don't know. And so this paper was published. This is the most recent paper which was published, which was in the British Journal of Dermatology, which is the sort of main British journal for which we publish in. And this looked at 428 consecutive people from this region of the UK who had been diagnosed with melanoma. And the doctors who did it, the nurses who did it, looked back and saw how many of those patients had previously been seen in the same hospital within the last year for the same lesion. They found 9 of the patients had been. So that suggested they were probably missing about 1 in 50 cases, something like that. That's approximate figures. So they were missing, but then on the other hand, the patients did come back. So the patients came back within a year, so maybe they were safety netting the patients and bringing them back again. This is why I was going back to the message that just because somebody tells you that your lesion is okay, it is really important to keep on just checking it. And if it's not okay, just go back and say to the person, look, I know you said it was okay, but you did say come back if it's changing, and it's changing. And no sensible doctor is ever going to be upset about somebody coming back in that situation, because it's life-saving. If you can then make the diagnosis, yes, you've been delayed a few months, but it probably won't make that much difference compared to being delayed 2 or 3 years and coming back with disseminated disease. So this is the really important message I took back from this. Now, I think it's fair to say this research has had a mixed reception amongst British dermatologists, as you might imagine. I'm somebody who just accepts, if you read it, accept it, well, there's the evidence. Okay, we have to live with it, we have to work with it, and we have to go forward from that. But I think a lot of people are going to repeat this research to see if it actually is true. Some of my colleagues say that can't be true, that's just that particular hospital, and we all know they're not very good there. But I don't think that's true. I mean, I know this hospital, I think it's fairly, it's right in the middle of the pack, I'd say, this hospital is. It's not particularly good, not particularly bad, but it's I'd say it wouldn't surprise me if the other research shows similar results to this. But we will find out. That research will be done. That's why research is so important. And thank you very much to Melanoma Focus for ongoing funding of research in this area. So the main AI now being used in the English NHS is from a company, is a system called DERM by a company called Skin Analytics, and that's the only one being used widespread through the NHS at the moment. And this has been used, as I say, mainly to screen referrals which have been sent from primary care to secondary care, but it is also being piloted in primary care as well. And there have been several papers published on this, and we also have a website where you can look at what their performance is like. And it's been tested, I think, in about 10 or 20 different hospitals around England. There's about 100 hospitals with dermatology, so it's quite widespread use. Some of you may well have had experience of being screened by this AI already, because it's been around for several years. At the moment, the way it works is that when the AI looks at people, all the referrals coming into the hospital, and it selects out a small proportion of them, which it thinks are harmless. And at the moment, what happens almost everywhere is that those results are then second checked by a dermatologist who goes through them to see if they agree with that. But it is just beginning to be used in 1 or 2 places without that second check, just with the advice to people to safety net. So that is something which may be starting to happen soon. And they publish their results. This company who makes it published their results on the website, and with their permission, I emailed them. They said they're happy for me to show. This is a recent screenshot I just took from their website showing their figures. I would ignore the top figure. The negative predictive value is a very statistical sort of figure, and it depends on a lot of things. Is hard to interpret. The sensitivity is the main thing you want to know, because it means that if you've got a melanoma and you go to see somebody, what proportion of the time will they pick it up? And you can see here that the figure is around about 98% there, which is actually remarkably similar to the figure from the region of England, which we published in that paper. So that sort of suggests to me, it suggests to me we're looking at roughly the same sort of accuracy now from the AI as a human. And you're probably all a bit shocked. I was a little bit shocked that, 1 in 50, that sounds like quite a lot, doesn't it? 1 in 50 being missed. And it does make you think, you do have to keep an eye on it. And, that lesion, if you're told it's benign and if you're worried about it, do go back. So it's important to read research with an open mind. And so when people stand up and show you figures, percentages, statistics, keep an open mind. Was this English hospital, was it really representative, or was it particularly good, or was it particularly bad? Now, I know some of the people in the company, and they seem honest, very straightforward people to me, but there have in the past been examples of pharmaceutical companies representing data perhaps in a slightly favourable way, towards themselves. Perhaps I've been Mr. Cynical here saying that, but it has been known. So you have to be slightly sort of critical about it. And also the question, if 1 in 50 melanomas is being missed by clinicians and by this machine, why aren't the courts absolutely full of people? Because how many melanomas a year are there diagnosed in England? It's about 18,000, something like that. And 1 in 50 of that is about 900 per year. So that suggests about 900 people per year having a melanoma missed under our current system. So why aren't the courts absolutely full of people suing doctors and suing companies for this? And the answer, of course, is probably because of safety netting, which we talked about before. So if you come along to see me and I'm not quite sure, I'll probably just say, let's cut it out. But you actually might say, I'm fed up of having things cut off my skin, or it's in a really sensitive area on my cheek, you know, on my breast or my genital. Do I really have to have it cut out? And it's, okay then, well, you know, I think it's okay. I'm not 100% sure, but I thought you keep an eye on it, and I'll see you again in 3 months' time, or 4 months' time, or 6 months' time. And if it's changed, we will cut it out. And you might say to me, yeah, okay, that sounds fair enough. And I'll see you again in 3-6 months' time, and it has changed, and we'll cut it out, and it's a melanoma, an early melanoma. Now, that's a missed melanoma, because I could have diagnosed it in the first place. But you and I might both think, well, actually, we made a shared decision-making. We talked about it. I brought you back after 6 months, and we have cut it out. Yes, there's been a delay of 6 months, which might have an adverse effect, but might not do, you know. And so overall, you might decide not to sue me at the end of that consultation. You know, you might decide, I don't know, but you know, and you know, we might both go away from that consultation thinking, oh well, thank goodness you came back. You know, you did what we said, and we've identified it. So, and that's what safety netting is. And that's what I'm trying. The main message from this talk is safety net. You know, just make sure that if something's changed, you go back and ask again, and don't believe in anybody, don't believe in any doctors or any machine or anything to 100%. You know, machines are just machines, humans are just humans. So this is just a little bit of how is the AI being used? And I think I've spoken about this already. There are about 100 units in the UK. About 20 of them are now using this. It's also been used in primary care as well. I've talked about how it's been used with a second read. The dermatologist is checking it. But really, it would be most efficient in the future if we could find a way of using it without... Can you imagine the time involved? You know, for the dermatologists to go back and second check the AI every single time. If you could free up those dermatologists and get them reducing waiting lists elsewhere, that would be so much more efficient for the NHS. And that would be what we really would hope to be able to achieve in the future. If you've got an AI which will actually just chunder away by itself, be as accurate or better than a human, and as long as people don't believe in it too much. And that's the challenge. It's interesting when you ask people a question about would you prefer a human or an AI. A lot of people actually would prefer an AI because we see so much on films, don't we? I love science fiction films, don't you? And you see a science fiction, we think, oh yeah, it's so much smarter than humans. It's bound to be better. But you know, and I think it's just bearing in mind that it might be better, but it might not be. What about NICE? You know, the government body which regulates new things like this. Oh, 5 minutes. Okay, so okay, almost finished. NICE are looking at this technology, and they're due to produce a report soon, probably in the next month or so, saying whether or not they approve of it. The challenge with this is what I've talked about in the next slide, is about research and AI. When a drug company brings out a new drug for us, what it does, it produces the drug. It then tests it for 8 years, 9 years, and then it gets a safety license, and then it's launched, and then it's on patent for another 10 years or so the drug company can make their money back from the hundreds of millions of pounds they spent developing the drug. That's all very well if you've got a particular compound. The problem with AI is it updates every 6 months or every year, isn't it? So you can't do that process. If you do a study which takes 3 years to report, by the time the report comes out 3 years later, the AI has been updated 4 times since. So what you're actually looking at here is nothing like the stuff on which you've done research. So the traditional method of doing research for healthcare just doesn't work. And that's something we've all been scratching our head about. That's how NICE works. They look at the traditional model of health, of published research and this is what evidence-based medicine is all about. So one of the hats I wear is I work for something called the NHR, which is the National Institute of Health Research. And you know, we've been thinking about that, trying to think about how we can develop research for artificial intelligence, which is updating all the time, because it's not just for skin, it's also for, so it's not just, I didn't mean to say just, it's not only for skin, it is also for eyes, it's for breast cancer, it's also all sorts of other things. We have to find new ways of doing research which will be responsive to rapidly changing technology. So the question which I'd ask is, are we now close to a tipping point in 2025? Because the data seem to show that humans and AI may be similar performance for melanoma diagnosis, possibly. Might we soon get to the point where the public would actually prefer to get an AI rather than to see a doctor? You know, that is if the AI gets better, if doctors stay at 1 in 50, and the AI gets down to only 1 in 200, maybe you'd be all the public saying, well, look, actually, I'm not happy just seeing a clinician. I want to see an AI. There'll always be a need for a human touch. I'm not packing my bags yet, but as I said at the beginning of the talk, I'm planning to retire in a few years, so maybe. Now, I've just written down in my last 2 minutes, am I okay? Two minutes of just some personal views on the important principles, things which may be questions you'd be thinking. Number one, the public, the patients need to be fully informed and agree to this. You have to be able to consent to this with an opt-out option until it's fully established. And the problem will be, it will always be developing. So it just is a need for communication, which is why I was so pleased to get this opportunity to talk today. Safety data from AI, the analysis must be open to independent analysis so people can look at it and truly understand and accept it. It's important that, remember, all this data being gathered on patients from England is all valuable data. You know, we've heard about big data being very valuable. And I was listening on the radio to the talks, between our politicians talking about the value of data from the English NHS. It's really important that data is retained within the NHS so that it can be used to benefit patients in England here and the UK in the future. And isn't given away to a big corporation where we have to actually buy it back off them. That's really important. There are many companies. There's one company at the moment, which I've mentioned before, who's working in this area, but we have to be open to new companies. There's lots of brilliant people out there coming up with new ideas, but we have to be open to it. But we also have to have a process of testing new technology to make sure it's safe before it comes in there. We don't want to try and give away this is an area where Britain is really innovative. And what we really don't want to do is give away British ingenuity and work which has been done in the UK to other countries to then profit and boost the value of various big tech shares over in other countries. We'd like that wealth to stay in England to benefit us through taxation, which will go into the NHS and improve services for everybody. And the key thing is putting safety first, but at the same time, put safety first, but in a way which doesn't actually stifle innovation. To try and get those two things together is the really tricky thing. So thank you very much for listening to me.